Welcome back to the Deep Dive. Today, we are embarking on a massive guided tour through one of the most complex production facilities in the human body, the male reproductive system.
Mhm.
We've pulled an extensive chapter summary from a major histology textbook, and our goal is to give you a complete, structured understanding from the single genes that determine sex right down to the microscopic mechanics of delivery.
That's absolutely right. Think of this as getting the master blueprint. If you are a college student prepping for an exam or, simply someone who thrives on highly detailed technical knowledge, this is your shortcut.
So we're building it from the ground up.
We will build a system piece by piece, ensuring we connect every structural component, the morphology, to its physiological purpose and its clinical relevance, covering every specific term and pathway exactly as it's laid out in the source material.
Okay, let's unpack this. Our mission is total coverage, but we start with the high-level schematic. Figure 22.1 in our source outlines the whole operation. What are the four major architectural components we need to track?
We're dividing it into organizational units. So first you have the engine room, the paired primary organs, the testes.
Right.
Second, the plumbing network, which are the genital excurrent ducts. That's the transport system.
Okay.
Third, we have the manufacturing support team, the accessory sex glands. This includes the seminal vesicles, the large prostate, and the bulbourethral glands.
And the fourth?
Finally, the external genitalia, which is the penis and scrotum, which house and deliver the product.
And the testes, the workhorses of the system, have dual responsibilities. What are their twin tasks?
They perform two distinct critical functions. First, spermatogenesis, which is the continuous production of the male gametes, or sperm.
The production line?
Exactly. Second, steroidogenesis, which is the synthesis of sex hormones, primarily androgens, with testosterone being the star molecule.
And that testosterone is key for more than just, secondary characteristics.
Oh, absolutely. Critically, testosterone doesn't just drive those things. Locally, it is absolutely essential for maintaining spermatogenesis once it starts, and globally, it governs sexual dimorphism.
So let's zoom in on the testes themselves. These are paired ovoid organs housed outside the body cavity in the scrotum. Structurally, how is this primary organ contained and suspended?
Well, they are suspended by the spermatic cords and are anchored inferiorly by scrotal ligaments, which are actually remnants of a fetal structure called the gubernaculum.
Okay.
And the capsule is a defining feature. It's a thick, dense connective tissue layer called the tunica albuginea. Just inside that, we find a looser inner layer, rich with blood vessels, aptly named the tunica vasculosa.
And the source notes that this capsule isn't just a wrapping, it's an organizer.
It is. The tunica albuginea sends these incomplete connective tissue sheets, or septa, projecting inward.
Like walls.
Exactly, like little walls that functionally divide the testes into approximately 250 conical compartments, which we call lobules. This gives the organ its internal architecture.
And what about the backside?
Along the posterior aspect, where the albuginea thickens considerably, we find the mediastinum testis, which acts as the central hub for the outgoing duct system and all the blood vessels.
Incredible structure. But the ultimate structure is dictated by a cascade of genes that starts way, way back in embryonic life. We are talking about the determination of sex. Where does the clock start ticking?
The clock starts with genetic sex determination right at fertilization, defined by the presence of the Y chromosome.
Simple enough.
But the actual formation of the testis-gonadal sex determination doesn't begin until the 7th week of gestation. And this crucial event is driven entirely by the SRY gene, the sex-determining region Y, found on the short arm of the Y chromosome.
That SRY gene is famously the master switch, but how does it flip the switch at a molecular level? What's it actually doing?
So when SRY is expressed in what's called the bipotential gonad, it produces the testis-determining factor, or TDF. PDF is a transcription factor, and its function is remarkable. It binds to the DNA and physically alters the strand to form a distinct loop.
Wow, it bends the DNA itself.
It literally rewrites the structural shape of the DNA. And that structural change is what permits other necessary transcription factors to bind, which then initiates the entire complex program for male differentiation.
And we see how absolute critical this master switch is in conditions like Swyer syndrome.
Precisely. If there is a mutation or, a complete absence of the SRY gene in a genetically 46XY individual, the individual develops the female phenotype.
So they have a vagina and uterus.
Yes, but they lack ovaries. It's a condition called gonadal dysgenesis. They can't produce sex hormones and require hormone replacement to induce puberty. It's a perfect example of a single gene determining the destiny of an entire system.
Now, SRY doesn't work alone. Let's quickly look at the supporting genetic crew described in our source.
Right, there are several key regulators. The WT1 gene is essential for general urogenital development and actually regulates the transcription of SRY itself. Then there's SOX9, which is pivotal because it activates the gene for Müllerian-inhibiting factor, a key defeminizing step. A mutation here can lead to 46XY individuals developing ambiguous or female external genitalia.
So SRY flips the master switch, and SOX9 handles the destruction of the female template. What regulates the steroid factory?
That's the job of the SF1 gene,
Yeah.
steroidogenic factor 1. It regulates the expression of all the genes involved in hormone synthesis in the Leydig cells.
And what about the last one, DAX1?
And finally, we have the fascinating DAX1 gene on the X chromosome, which normally acts as an antagonist. It actually suppresses SRY activity.
So it's a braking system.
Kind of. Mutations in DAX1 cause congenital adrenal hypoplasia, which shows its role in managing this intricate hormonal balance. It's a genetic ballet, as you can see.
Now that the genes have set the program, let's look at the tissues involved. Figure 22.2 details the three distinct embryological sources of the testes.
The first source is the intermediate mesoderm, which forms the urogenital ridges on the posterior abdominal wall. This mesoderm gives rise to the Leydig cells and the myoid cells. Those are the contractile cells of the tubule wall.
Okay, that's what.
Second, the mesodermal epithelium, or coalomic mesothelium, which lines those ridges. This tissue forms the primary sex cords, which grow inward and differentiate to become the seminiferous cords, giving rise to the essential Sertoli cells.
And the third source is the most remote.
The primordial germ cells. These cells originate completely outside the developing gonads, specifically in the yolk sac, and must actively migrate into the primary sex cords.
So they're immigrants, essentially.
They are. Once they successfully integrate, they differentiate into gonocytes, which are the immediate precursors of the spermatogonia, the stem cells for sperm.
With the components in place, figure 22.3 shows us the power of hormonal sex determination, how the early testis physically dictates the development path of the rest of the embryo.
The SRY expression in the pre-Sertoli cells orchestrates the entire process. There are three hormonal heavyweights here. First, testosterone, produced by the developing Leydig cells, is responsible for building the male internal system.
How so?
It stimulates the development of the mesonephric, or Wolffian, ducts into the definitive male genital excurrent duct system.
And the second hormone is responsible for the crucial act of defeminization.
That's Müllerian-inhibiting factor, MI, secreted by the Sertoli cells within the cords. MIF is a large glycoprotein, structurally similar to TGF-beta, and it acts to inhibit the paramesonephric or Müllerian ducts.
Which would otherwise become the uterus and fallopian tubes.
Exactly. This ensures those ducts regress and prevents the formation of the uterus, fallopian tubes, and the upper part of the vagina.
Finally shaping the external features.
That requires a different, more potent form of the hormone, dihydrotestosterone, DHT. Testosterone is converted into DHT by the enzyme 5-reductase. DHT is the hormone that drives the development and differentiation of the external genitalia from their sexually indifferent state.
So without that conversion, you'd have a problem.
A big one. If this conversion fails, the external anatomy defaults to the female pattern, even if the internal male structures are present.
We've established formation, now location. The testes develop in the abdomen and must ascend. Why does this descent happen and when?
The descent typically occurs around 26 weeks of gestation. It's driven by two factors: the rapid growth of the abdomen and the testosterone-induced shortening of the gubernaculum. They must pass through the inguinal canal and end up in the scrotum.
This migration is not optional. Failure leads to cryptorchidism, and the source makes it clear that temperature is the driving problem.
It's a common issue. 30% of premature infants and 1% of full-term infants experience cryptorchidism or undescended testes. The risk of leaving them in the warmer abdominal cavity is high.
What kind of risk?
It causes irreversible histologic damage to the germ cells and significantly increases the risk of testicular cancer later in life. That's why surgical correction, orchiopexy, must be performed before age 2.
Why is temperature such a killer for the testes?
Spermatogenesis requires a stable temperature 2 degrees C to 3 degrees C below core body temperature. That lower temperature is essential for sperm production.
But not for hormones.
Interestingly, no. Leydig cell spermatogenesis is not temperature dependent, but heat stress from a fever, a varicocele, or a sedentary lifestyle rapidly induces apoptosis and DNA damage in the sensitive dividing cells.
So the body has evolved a complex two-part system to manage this thermoregulation, which I find incredible. Tell us about the passive system first.
The passive system is a brilliant piece of vascular engineering called the countercurrent heat exchange mechanism. The convoluted testicular artery carrying warm arterial blood from the aorta runs immediately adjacent to the pampiniform venous plexus,
Which is a dense network of
a
veins.
very dense network carrying cooler blood back from the scrotum. Heat naturally transfers from the warm arterial blood to the cooler venous blood, pre-cooling the arterial supply before it ever enters the testis.
And the active regulation involves two muscles.
Yes, the muscular control adjusts the position and surface area. The cremaster muscle, derived from the internal abdominal oblique, is skeletal muscle. It contracts to pull the testes closer to the body when cold, or relaxes to lower them when hot.
And the second muscle.
Below that, in the scrotal fascia, is the dartos muscle, a thin sheet of smooth muscle. Its contraction wrinkles the scrotal skin, reducing the surface area to regulate heat loss. It's a highly sophisticated thermal management system.
Having established the container and the environmental controls, the temperature and the hormonal switches, let's finally get into the cellular factory itself.
Inside those 250 testicular lobules we described, we find the factory floor. 1 to 4 highly convoluted seminiferous tubules. These are astonishingly long, up to 50 centimeters each, where sperm production occurs.
And what's in the interstitial space, the stroma surrounding these tubules, figure 22.5, gives us the context.
That stroma is packed with connective tissue, vessels, and the crucial interstitial cells, the Leydig cells, which are busy producing testosterone. The tubules themselves are blind-ended, but near the mediastinum testis, they straighten into the straight tubule, or tubulus rectus, which connects to the rete testis, that anastomosing channel network that moves the sperm out.
The seminiferous tubule itself is lined by what our source calls an unusual, complex, stratified epithelium. Why is it unusual?
Well, because it's composed of two completely different coexisting cell lineages. First, you have the non-replicating Sertoli cells, also called sustentacular cells.
Nurse cells.
Exactly. They are the true columnar epithelial cells, extending the full thickness, providing structure, and enveloping the entire process. They are the nurses of the system.
And second, the cells of the product line.
The spermatogenic cells. These cells, derived from the primordial germ cells, are organized strictly by their developmental stage. The most immature cells, the spermatogonia, sit right on the basal lamina,
And they move inward as they mature.
progressively inward, with the final products, the spermatids, attached apically near the lumen.
What's supporting the tubule from the outside?
A supportive multi-layered connective tissue called the tunica propria, or peritubular tissue. It lacks typical fibroblasts. Instead, we see 3 to 5 layers of specialized cells called myoid cells, peritubular contractile cells.
So they are contractile, meaning they resemble smooth muscle.
Yes, they generate the rhythmic peristaltic waves. This muscular action is vital because the newly produced sperm are completely non-modal. The contractions must physically push the fluid in sperm out of the convoluted tubule toward the rete testes.
And they do more than just contract.
Right. Our source also highlights that they have a dual role, as they also synthesize collagen, making them functionally similar to fibroblasts. And clinically, thickening of this layer is a histological marker associated with aging and decreased fertility.
Now let's talk about the architects of the hormonal environment, the Leydig cells, found right there in the stroma. What makes their morphology jump out in a micrograph?
They are large, polygonal, and intensely eosinophilic, so they stain strongly pink because they are packed with machinery for hormone synthesis. Figure 22.7 shows the hallmark features of a steroid-secreting cell: an elaborate, smooth endoplasmic reticulum, SER, and mitochondria, with characteristic tubulosiccular cristae. They also typically contain numerous lipid droplets.
And this is where we get to one of those truly bizarre histological curiosities. The Leydig cells have an inclusion that scientists still don't fully understand.
It's fantastic. Figure 22.8 illustrates the crystals of Ranke. They are distinctive rod-shaped cytoplasmic crystals, easily visible and refractile under light microscopy in human cells.
But we don't know what they do.
We don't. They are almost certainly a stored protein product, but despite being known for decades, their precise function is still listed as unknown. It's one of those beautiful little mysteries the body holds onto.
Let's discuss the function of these cells. Their testosterone is, of course, critical for development and secondary characteristics, but what else are they producing?
Besides testosterone, they also secrete insulin-like protein 3, INSL3, which is involved in stimulating testicular descent in fetal life and later appears to stimulate meiotic divisions within the tubules.
Interesting.
And intriguingly, they produce a local hormone, testicular oxytocin, which acts right there in the testes to stimulate the contraction of the myoid cells surrounding the tubules.
And when Leydig cells become pathological,
They often form Leydig cell tumors. These are usually benign, but are hormonally active. This hormonal output leads to dramatic clinical manifestations.
such as,
In children, they cause sexual precocity, meaning early puberty. In adults, they often secrete estrogens alongside androgens, which can lead to feminization or gynecomastia.
Folder 22.1 brings us back to the master control, the hypothalamus-pituitary-gonadal axis, HPA, regulating the whole system.
It's a classic feedback loop. The pituitary releases luteinizing hormone, LH, sometimes called ICSH. LH travels via the bloodstream and acts directly on the Leydig cells, stimulating them to ramp up testosterone production. Prolactin, PRO, also plays a supportive role, synergizing with LH.
So LH feeds the factory floor, but how does the pituitary regulate the Sertoli cells, the true organizers of spermatogenesis?
That's the job of follicle-stimulating hormone, FSH. FSH acts on the Sertoli cells, but needs a partner. The local testosterone concentration, which is, as we noted, up to 200 times higher than what is circulating in the blood.
200 times, wow.
Yeah, Sertoli cells possess receptors for both FSH and testosterone, making them the ultimate orchestrators of the entire sperm production process.
This high level of hormonal dependency is why male testosterone-based contraceptives were initially researched. Right?
Exactly. The concept is that by introducing high levels of exogenous testosterone, the body shuts down the pituitary through negative feedback, dramatically lowering the production of endogenous testosterone.
And that crashes the local supply.
It successfully crashes that critical 200x local concentration required by the Sertoli cells, thereby inhibiting spermatogenesis. However, the source points out that side effects like acne and depression, and the fact that some men show non-suppression, have complicated clinical studies.
Moving to folder 22.2, let's revisit the sheer fragility of the spermatogenic cells. Why are they so susceptible to external noxious agents?
Well, they are actively dividing, rapidly differentiating cells, making them highly vulnerable to metabolic stress or toxins. The source lists numerous factors that cause degenerative changes: apoptosis, sloughing, or forming abnormal multinucleated giant cells.
What are some examples of these negative factors?
We see impairment from dietary factors like deficiencies in vitamin A, C, E, zinc, or selenium. Environmental factors are key. For example, epidemiological studies comparing urban and rural men have shown significant differences in median sperm count.
And things like illness.
Absolutely. Systemic issues like high fever or localized infections, or chitis, also have a rapid negative impact.
And temperature, once again, is a major threat.
A critical one. Elevated temperature, whether from a varicocele, that's dilated veins in the scrotum, or sustained heat exposure from certain sedentary lifestyles, severely compromises the process.
Right.
Finally, we must note toxic agents like the pesticide DBCP, phthalates found in plastics, other endocrine-disrupting chemicals, and ionizing radiation.
But some cells are more resilient.
The important immunological distinction here is that the non-dividing cells, Sertoli cells, Leydig cells, and the reserved stem cells, are much less susceptible than the rapidly dividing germ cells.
Now we get to the core product. Spermatogenesis, the 74-day manufacturing marathon where spermatogonia become mature sperm. It's continuous, begins at puberty, and is fundamentally divided into 3 phases. Let's start with phase 1, the spermatogonial phase, which is all about mitosis and renewal.
Right. This phase serves 2 purposes: replacing the stem cell population and producing committed cells that are ready to differentiate. Our source helps us distinguish 3 types of spermatogonia based on their nuclear morphology, which is helpful in histology.
Give us the visual breakdown.
First, type A dark-at spermatogonia. They have intensely basophilic, finely granular chromatin, and they are the reserved stem cells, dividing irregularly. Second, type A pale spermatogonia. They have lightly staining chromatin and are the renewing stem cells committed to differentiation. They undergo several mitotic divisions to expand their clone size.
And finally,
Third, type B spermatogonia, which have spherical nuclei with condensed chromatin clumps, marking the final stage before they enter meiosis.
and figure 22.9 illustrates the most bizarre biological arrangement here: clonal development.
It's a key piece of engineering. When an spermatogonium divides, the daughter cells and all subsequent progeny through mitosis and meiosis remain connected by cytoplasmic bridges. They don't fully separate.
So they're all physically linked.
Yes, it results in a syncytium, a clone of cells that develops in perfect synchrony. ensuring they all mature together. These bridges remain intact until the very end of maturation.
Phase 2 is the spermatocyte phase, defined by the reduction division, meiosis.
The type B spermatogonia divide mitotically to form primary spermatocytes. Crucially, before meiosis begins, they replicate their DNA. So they start with the normal chromosome number 2-on, but double the DNA content, 4-pin.
And meiosis the sest is where the real genetic variety occurs.
Meiosis the first is the long haul, lasting about 22 days in humans, dominated by prophase of first. This is where homologous chromosomes pair up as tetrads for chromatids and undergo crossing over, exchanging genetic material.
Right, shuffling the deck.
Exactly. They form the synaptonal complex before separating randomly to opposite poles as diodes. This is the reduction division, resulting in secondary spermatocytes, which are now truly haploid in chromosome number 1n, but still contain a second amount of DNA.
Then the rapid second division.
Meiosis the second happens immediately, without any further DNA synthesis. The sister chromatids separate, resulting in 4 final haploid cells, spermatids.
With one N chromosome number and 1D DNA content.
Exactly, 23 single-stranded chromosomes. This is the cell that must now be radically transformed.
Phase 3, spermiogenesis. This is not division, but extreme cellular remodeling. Figure 22.11 summarizes the 4 morphological phases involved in turning a round spermatid into a streamlined sperm.
Starting with the Golgi phase. The Golgi complex produces proacrosomal granules that coalesce into the membrane-bound acrosomal vesicle, establishing the anterior pole.
The front end.
Precisely. Simultaneously, centrioles move to the posterior pole to initiate the assembly of the 9+2 microtubule arrangement of the flagellar axoneme.
Next, the cap phase.
The acrosomal vesicle spreads over the anterior half of the nucleus, forming the acrosome cap. Inside the nucleus, the chromatin undergoes a massive change. DNA condenses drastically. It shrinks to about 1/6 the size of mitotic DNA, as the core histones are replaced by small, highly basic proteins called protamines.
Then the acrosome phase, where the characteristic shape emerges.
The spermatid head embeds into the Sertoli cell, and the flagellum extends into the tubule lumen. The nucleus flattens and elongates. Cytoplasmic microtubules form a temporary sheath called the manchette, which extends posteriorly before disappearing.
Right.
The centrioles form the connecting piece, the neck region, and 9 protective coarse fibers, outer dense fibers, develop peripheral to the axoneme.
This is also where the sperm gets its power supply.
Exactly. The mitochondria migrate and wrap tightly in a helical sheath around the coarse fibers in the neck region, forming the definitive middle piece. This provides the ATP for motility. Distal to that is the long principal piece, reinforced by a fibrous sheath, and the final end piece, containing just the axonomal complex.
The final step of remodeling is the maturation phase.
The unnecessary cytoplasm is removed, forming the residual body, which is promptly phagocytosed by the surrounding Sertoli cells. The last step is the disintegration of the intercellular bridges, allowing the mature but still non-motile spermatozoa to be released into the lumen.
That complex release process has its own name, spermiation.
Spermiation is the actual detachment of the elongated spermatids from the Sertoli cells. It's highly regulated, involving the removal of specialized junctions, possibly through regulatory enzymes like integrin-linked kinase.
And if it fails?
Failure of spermiation means the sperm are retained and phagocytosed by the Sertoli cell, reducing the usable sperm count.
Figure 22.12 gives us the structural anatomy of the final sleek product.
The mature sperm is about 60 micrometers long. The head is flattened, about 4.5 mem. The acrosomal cap covers the anterior 2/3 and is basically a modified lysosome packed with hydrolytic enzymes.
What kind of enzymes?
Hyaluronidase, acid phosphatase, and acrosin. These enzymes are absolutely essential for breaking through the specialized layers surrounding the egg, initiating what's called the acrosome reaction.
And revisiting the tail structure.
We have the neck, the middle piece, 7M with its mitochondria power plant, the long principal piece, 14, where most of the whipping action occurs, and the final end piece.
Now, a key point we must emphasize. Newly released sperm are completely non-motile. They are moved passively by fluid and myoid contractions through the straight tubules and the retestis, and then they enter the epididymis.
That's the critical post-testicular maturation step. They acquire true motility and undergo essential changes over the estimated 12 days they spend traversing the epididymis. This maturation is androgen-dependent and involves further DNA condensation and changes to the plasma membrane.
And the most important change in the epididymis is temporary inhibition of their function.
Yes, that is decapacitation. The epididymal principal cells add surface-associated decapacitation factors, these are glycoconjugates, to the sperm membrane. This temporarily inhibits their fertilizing ability, keeping them quiet and conserved for storage in the tail of the epididymis.
But they do learn how to swim there.
Yes, the initiation of motility, which they acquire here, is linked to key intracellular changes in Chem-P, calcium, and pH.
The functional flip side, then, is capacitation.
Capacitation is the final physiological change required. It happens only after the sperm are deposited in the female reproductive tract, where they survive for about 2 to 3 days. This process involves the removal and replacement of those inhibitory glycocalyx components, finally enabling the sperm to fertilize the ovum.
We discussed the synchronization of the developing cells due to the cytoplasmic bridges. This synchronization defines the cycle of the seminiferous epithelium.
The cycle is the fixed series of cellular associations that occur sequentially at any given location in the tubule. In humans, 6 distinct stages, I through VI, are defined, primarily based on the specific morphology of the developing spermatids.
And the duration is fixed and constant, which is a key clinical takeaway.
It is. The duration of one cycle is about 16 days. But the total time from a stem cell committing to differentiation until it's released as a spermatid is approximately 4.6 cycles, or 74 days.
Wow.
Add the 12 days for epididymal transit, and you have the clinical lag, 86 days. If you start a treatment, you won't see its full effect on the ejaculated sperm for nearly 3 months. This production line is massive, estimated to produce about 300 million sperm cells daily.
Now, figure 22.14 contrasts humans with other species using the concept of the wave of the seminiferous epithelium.
The wave is about how these stages are arranged along the length of the tubule. In species like rodents, the stages are clearly sequential, forming a wave, meaning if you take a cross-section, you almost always see just one stage of the cycle.
But not in humans.
But in humans, there are no waves. The 6 stages are arranged in random, patch-like distributions, a mosaic pattern. If you look at a single cross-section, you might see up to all 6 stages arranged like pie wedges in the epithelium.
Let's dedicate some serious time to the unsung hero, the Sertoli cell, the non-replicating epithelial cell that manages this entire process.
Sertoli cells are tall, columnar, and highly active, which is reflected in their euchromatic nucleus. It's often ovoid or triangular with deep infoldings. Their structure is defined by an elaborate cytoskeleton, which is crucial for their mechanical roles.
What are the key cytoskeletal components? Figure 22.15 and 22.16 highlight this internal framework.
They have abundant microtubules, oriented with their minus ends toward the apex, which are responsible for the precise repositioning of the developing elongated spermatids as they mature.
Okay.
Intermediate filaments form a paranuclear sheath, and dense actin filaments reinforce the membrane near the junctions.
And they have their own unique structural mysteries specific to human cells.
Yes, the Charcot-Butcher crystalloids found in the basal cytoplasm. These are fusiform crystalloids made up of 15-millimeter filaments. We maintain them in our description because they are a classic histological marker for identifying human Sertoli cells, though their function, possibly related to lipid transport, remains unproven.
Now, the most critical structure, the Sertoli to Sertoli junctional complex, shown in detail in figure 22.1c. What makes this junction unique in the body?
It's an engineering marvel. It starts with an exceedingly tight junction, zonula occludens, sometimes involving over 50 parallel fusion lines, making it one of the tightest barriers in the body.
But there's more to it.
That's not all. It's reinforced by 2 unique cytoplasmic components: a flattened cisterna of smooth endoplasmic reticulum running parallel to the membrane, and tightly packed hexagonal bundles of actin filaments positioned between the SCR and the membrane.
This complex physically divides the epithelium, creating 2 distinct physiological spaces, as seen in figure 22.16.
This is the basis of the entire system. The junction divides the space into the basal compartment, which houses the primitive cells, the spermatogonia, and early primary spermatocytes.
Yeah.
Everything above that junction is the luminal compartment.
And that contains the more mature cells.
The genetically modified cells, the later primary spermatocytes, secondary spermatocytes, and all spermatids.
Wait, if the barrier is so tight, how do the early primary spermatocytes get through it to enter the luminal compartment?
It's a precisely timed movement. They must differentiate and pass through this complex, but they do it by forming a new junction beneath the cell before the existing junction above the cell is broken down. This ensures that the integrity of the barrier is maintained at all times. Nothing leaks through during transit.
That barrier is the blood-testis barrier. Why is maintaining that integrity the single most important non-nursing function of the Sertoli cell?
Immunologically, it is life or death for the germ cells. Spermatozoa and mature spermatogenic cells possess unique antigens. Since they are produced only at puberty, long after the systemic immune system has been fully established, the body recognizes them as non-self and would launch a massive immune attack. The blood-testis barrier physically isolates these genetically different haploid cells from the circulating immune system.
Folder 22.3 details the clinical consequences of a barrier failure.
If the barrier fails, perhaps due to trauma, infection, or surgery like a vasectomy, those sperm-specific antigens leak out and are exposed to the immune system.
And that causes problems.
This results in the production of anti-sperm antibodies, often IgA, which can cause sperm agglutination, clumping them together, leading to infertility. The barrier's integrity is non-negotiable for fertility.
Beyond protection, Sertoli cells also have a massive secretory and supportive role. Let's quickly detail their functions.
They have both exocrine and endocrine-paracrine roles. Exocrine secretions include the necessary fluid for passive sperm transport and androgen-binding protein, ABP, which acts like a sponge to maintain that required 200x local concentration of testosterone in the lumen.
And the nursing side?
Their nursing functions involve phagocytosing the residual bodies and any non-differentiated or apoptotic germ cells.
And their endocrine role involves communicating back to the brain.
They secrete the glycoprotein hormone inhibin, which participates in the negative feedback loop to the anterior pituitary, specifically inhibiting the release of FSH. They also produce growth factors and transport proteins. Their life revolves around high FSH and high local testosterone.
Sperm are produced, now they must be transported out of the testes via the intratesticular ducts. How does the convoluted seminiferous tubule abruptly end?
It transitions into the straight tubuli or tubuli recti. This is a short segment that is histologically distinct because the germ cells vanish. It is lined only by Sertoli cells.
The straight tubules then empty into the ret testes.
This is the complex anastomosing network of channels housed in the dense connective tissue of the mediastinum testis. The lining changes here to a simple cuboidal or low columnar epithelium. These cells are unique because they have a single non-motile apical cilium and sparse microvilli, which aids in moving the fluid.
The flow moves out of the testes and into the excurrent duct system. Figure 22.20 reminds us that this entire network, the epididymis, ductus deferens, and ejaculatory duct, developed from the mesonephric Wolffian duct under testosterone stimulation.
Correct. The first exit point is the efferent ductules. There are about 20 ductules that connect the retestes to the head of the epididymis, forming the conical masses, coni vasculosi.
Figure 22.21 and plate 22.3 show their unique epithelial pattern. What does it look like and why?
It's a pseudostratified columnar epithelium, but it features alternating groups of two cell types. We see tall, ciliated cells, which use their cilia to aid the mechanical movement of the non-motile sperm and fluid,
Right.
alternating with shorter non-ciliated cells possessing microvilli. These shorter cells are fundamentally important because they reabsorb most of the massive volume of fluid secreted by the seminiferous tubules.
And that contrast in cell height creates the very distinctive sawtooth or scalloped luminal appearance we use to identify the efferent ductules in a micrograph.
Exactly. And this is also where we see the first organized layer of thin, circularly arranged, smooth muscle appear, which provides the necessary peristaltic force to move the contents out and into the main maturation organ.
That maturation organ is the epididymis. It's highly coiled, 4 to 6 meters in length, though only about 7.5 centimeters overall, and divided into the head, body, and tail.
The epididymis is the critical transition zone. Its primary functions are final fluid reabsorption, sperm maturation, acquiring motility and undergoing decapacitation, and storage in the tail.
Plate 22.3 and figure 22.23 illustrate its epithelium, pseudostratified columnar with two cell types.
The principal cells are the tallest in the head and decrease in height toward the tail. Their defining feature is the presence of extremely long, rigid, non-motile microvilli called stereocilia.
And the other cells?
The basal cells are the stem cells. We also observe migrating halo cells, which are primarily lymphocytes involved in immune surveillance.
What are the principal cells doing on the molecular level?
They are powerful secretors and absorbers. They reabsorb the remaining fluid and phagocytose residual bodies and degenerating sperm. For secretion, they produce glycerylphosphocholine, sialic acid, and glycoproteins, all of which coat the sperm and contribute to the decapacitation process, keeping them quiescent until they are needed.
The muscle layer of the epididymis prepares the sperm for their final rapid journey.
The smooth muscle progressively thickens, particularly toward the tail, which serves as the principal reservoir. The tail adds inner and outer longitudinal layers around the central circular layer, creating a thick, powerful muscular coat.
So it becomes very strong.
Yes, these three layers contract intensely and forcefully during ejaculation to propel the stored, mature sperm.
That thick, powerful, three-layered muscular coat continues directly into the ductus deferens or vas deferens.
It's the direct continuation of the epididymis tail and ascends as the central component of the spermatic cord, bundled with the testicular artery, the pampiniform plexus nerves, etc. It enters the pelvic cavity, enlarges distally into the ampulla, and then joins the seminal vesicle duct to form the ejaculatory duct, which penetrates the prostate.
Figure 22.25 and plate 22.4 showcase the ductus deferens. It's essentially defined by its incredibly thick muscle layer.
Absolutely. It has a ridiculously thick wall, 1 to 1.5 millimeters thick, organized into those three powerful layers: inner longitudinal, middle circular, and outer longitudinal.
So it looks distinct.
Histologically, because of this massive coat, the lumen often appears irregular and star-shaped in sections due to muscle contraction during fixation. The epithelium remains pseudostratified columnar with stereocilia, similar to the epididymis.
This structure is the target of vasectomy, the male sterilization method. How does the body handle the continuous sperm production after this duct is severed?
Vasectomy involves clamping or severing the ductus deferens, blocking sperm passage. The testes continue producing sperm, which must be dealt with locally. Consequences include increased intraliminal pressure in the severed duct and the formation of a sperm granuloma, where macrophages congregate to phagocytose the backed-up sperm.
And the immunological consequence we mentioned earlier.
Yes, the leakage of spermatozoal antigens from the severed duct stimulates the immune system, leading to the production of IgA antisperm antibodies in a significant proportion of patients.
Is that dangerous?
Our sources make it clear, however, that while these antibodies are present, extensive research has found no proven link between this occurrence and increased risk of heart disease or other autoimmune complex diseases. Reversal procedures, vasovasostomy or vasoepididymostomy, remain complex but can achieve high patency rates.
The final sections of the duct are the ampulla and the ejaculatory duct.
The ampulla is characterized by taller, branched mucosal folds and a slightly thinner muscle coat. The ejaculatory duct, which carries both sperm and seminal vesicle fluid into the urethra, completely lacks its own muscularis layer, relying entirely on the surrounding fibromuscular tissue of the prostate for support.
We move now to the bulk contributors of seminal fluid, starting with the seminal vesicles, paired tubular glands posterior to the bladder.
They develop as evaginations of the mesonephric ducts and are highly unique morphologically. Plate 22.6 shows that their mucosa is thrown into extensive primary, secondary, and tertiary folds.
So it's very folded.
Extremely. When viewed in cross-section, this high degree of folding makes the lumen appear like a complex anastomosing network of mucosal arches or alveoli, dramatically increasing the secretory surface area.
And their epithelium morphology screams protein secretion.
It's pseudostratified columnar, with tall columnar secretory cells and basal stem cells. The secretory cells are dominated by well-developed RER and secretory vacuoles. This function is, like all others in this system, completely controlled by testosterone.
And the secretion itself is essential for sperm viability.
It provides the fuel. The seminal vesicles contribute 65% to 75% of the viscous whitish-yellow seminal fluid. It is extremely rich in fructose, which is the principal metabolic substrate, the energy source for the sperm.
What else is in it?
It also contains simple sugars, amino acids, ascorbic acid, and large amounts of prostaglandins. The smooth muscle surrounding the glands contracts intensely during ejaculation to discharge this secretion.
Next, the largest accessory gland, the prostate gland. It surrounds the prostatic urethra inferior to the bladder.
The prostate's primary role is secreting a clear, slightly alkaline fluid, pH 7.29, that accounts for 25% to 30% of the seminal fluid volume. Structurally, it consists of 30 to 50 tubulo-alveolar glands arranged in three concentric layers: an intermucosal layer, an intermediate submucosal layer, and the peripheral main glands.
Clinically, the prostate is always discussed in terms of its four distinct anatomical zones, as shown in figure 22.27, because different diseases strike different zones.
You have to understand the zones for clinical context. The peripheral zone is the largest, 70% of the gland, located posteriorly and laterally. This is crucial because most prostatic carcinomas arise here, making it the primary target for examination during a digital rectal exam.
Which zone is responsible for the universally common condition, BPH?
That's the transitional zone, which is only about 5% of the gland surrounding the prostatic urethra. This is the frequent site of benign prostatic hyperplasia, BPH, in older men, causing urinary compression.
Okay.
The central zone, 25%, surrounds the ejaculatory ducts and is notably resistant to both carcinoma and inflammation. Finally, we have the small periurethral zone and the anterior fibromuscular stroma.
Plate 22.5 shows the distinctive, often calcified inclusions found in the prostatic alveoli.
Those are the prostatic concretions, or corpora amylacia. There are concentric lamellated bodies, essentially precipitated secretory material or cell fragments that accumulate and increase in size with age, often calcifying. They're a classic marker for identifying the prostate gland histologically.
The source emphasizes that both normal and pathological prostate growth is regulated by DHT.
Absolutely. The glandular epithelial cells are equipped with 5-reductase, which converts circulating testosterone into DHT. DHT is significantly more potent, about 30 times more potent than testosterone. And its binding to the androgen receptor is the driving factor behind the epithelial and stromal proliferation seen in BPH and prostate cancer growth.
What are the key secretory components used as clinical markers?
The most famous is prostate-specific antigen, PSA, a 33 kDa serine protease, whose function is to liquefy semen. Normally, very small amounts circulate.
Less than 4 ng/ml.
Right. Elevated serum levels due to cancer, BPH, or prostatitis are used as a controversial screening marker. The severity of cancer is graded using the Gleason score. A secondary marker is prostatic acid phosphatase, PAP. Elevated serum PAP is an alternate marker, typically used for metastatic cancer. They also secrete fibrinolysin and citric acid.
Folder 22.4 details the dual clinical reality for aging men, BPH and cancer.
BPH, nodular hyperplasia, affects nearly all males by age 80, localized mainly in the transitional and periurethral zones. The pathogenesis centers on DHT, which acts in an autocrine fashion on stromal cells and paracrine on epithelial cells, causing proliferation that leads to urethral obstruction.
And treatments.
Treatments focus on either non-invasive methods, alpha receptor blockers, or 5-reductase inhibitors to reduce DHT levels, or surgical removal of the obstructive tissue, such as a turopy.
And prostate cancer, one of the most common male cancers, usually starts where?
In the peripheral zone. The risk increases with age, 1 in 6 lifetime risk. Treatment for advanced disease often involves hormonal therapy, depriving the cancer cells of the DHT they need by suppressing testosterone production via orchiectomy or GnRH agonists.
Finally, the last component is the bulbourethral glands, or Cowper glands.
These are small, pea-sized glands located in the urogenital diaphragm. Histologically, they are compound tubuloalveolar glands that resemble mucus-secreting glands, lined by simple columnar epithelium.
Also testosterone-controlled, I assume.
Yes. Their clear, mucus-like secretion is rich in galactose derivatives. It's released upon sexual stimulation as the preseminal fluid, serving the vital role of lubricating the penile urethra and neutralizing any traces of acidic urine before the main event.
We've covered all the sources of fluid. Let's look at the final mixture, semen.
Semen is the composite product. Sperm plus fluids from the testis, epididymis, ductus deferens, and all 3 accessory glands. It is alkaline, with a pH of 7.7, crucial for neutralizing the acidic environment of the male urethra and the female vagina.
And the volume.
The volume averages about 3 millil, containing up to 100 million sperm per milliliter.
And the percentages of fluid contribution?
The seminal vesicles provide the most, 65% to 75% fructose-rich, and the prostate contributes 25% to 30%. Despite the high concentration, we must remember that under normal conditions, approximately 20% of the sperm in any ejaculate are morphologically abnormal, and nearly 25% are emodal.
Moving now to the external genitalia, starting with the penis. Figure 22.3 and 22.31 show the 3 masses of erectile tissue.
We have 2 dorsal masses, the corpora cavernosa, and 1 ventral mass, the corpus spongiosum, which centrally contains the spongy urethra.
And they're all wrapped together.
All 3 are encased by the dense fibroelastic sleeve, known as the tunica albuginea. Internally, the erectile tissues are defined by wide, irregular vascular spaces caverns, lined by vascular endothelium, and separated by connective tissue and smooth muscle, forming structures called trabeculae or subendothelial cushions.
Blood flow is supplied by the deep artery of the penis, branching into the helicine arteries. This mechanism of vascular control brings us directly to the mechanism of erection, detailed in folder 22.5.
Erection is a complex neurovascular event. The initiation phase is driven by parasympathetic innervation. This stimulation causes the release of 2 key neurotransmitters, acetylcholine, ACA, and most importantly, nitric oxide, NO.
Nitric oxide.
NO acts as a potent signaling molecule, activating guanylate cyclase to produce cyclic GMP, cGMP.
And cGMP is the relaxation signal.
It causes trabecular smooth muscle relaxation and the dilation of the helicine arteries, allowing massive arterial blood flow into the cavernous spaces. This sudden influx of blood causes the expansion of the corpora cavernosa.
How does that expansion translate into rigidity?
The expanding corpora cavernosa physically compress the venules, the veins that normally drain the blood, against the non-distensible, rigid tunica albuginea.
So it traps the blood.
It traps it. This mechanism, called the corpal veno-occlusive mechanism, blocks venous outflow, trapping the arterial blood and resulting in tumescence and rigidity.
And the termination of the erection.
That's controlled by the sympathetic nervous system. Sympathetic stimulation causes the smooth muscle in the helicine arteries and trabeculae to contract. This contraction decreases arterial inflow and pressure, allowing the compressed veins to reopen and drain the excess blood, restoring the flaccid state.
Understanding the role of cGMP is why drugs for erectile dysfunction, ED, are so effective.
Yes. For many cases of ED, treatment involves phosphodiesterase inhibitors like Viagra or Cialis. They work by inhibiting the enzyme that rapidly degrades cGMP.
So they keep the relaxation signal around for longer.
By preventing the breakdown of cGMP, these drugs essentially prolong and amplify the natural relaxing effect of NO, improving the ability to achieve and maintain an erection under stimulation.
But if the underlying problem is nerve damage, interrupting the initial NO release, those drugs won't help.
Correct. If the parasympathetic signal is damaged, there is no NO and thus no cGMP to enhance. In those cases, the alternative treatment is often the direct injection of prostaglandin E1, PGE1 or olpathetol, into the corpora cavernosa.
And what does that do?
PGE1 directly causes relaxation of the vascular and trabecular smooth muscle, inducing vasodilation locally, bypassing the neurological signal and engaging the veno-occlusive mechanism.
Finally, the structure of the scrotum, that musculocutaneous pigmented pouch, described in figure 22.32.
The scrotum is a masterpiece of thermal engineering. It's homologous to the female labia majora. The skin is thin, wrinkled, and highly pigmented. Crucially, the subcutaneous layer of fat adipose tissue is absent.
Instead of fat, we have muscle for active thermal control, the dartos layer.
The dartos is smooth muscle, which replaces the hypodermis. It is firmly attached to the dermis and has two perpendicular layers. Its contraction, when cold, wrinkles the scrotal skin and elevates the testes, reducing surface area for heat loss. Relaxation, when hot, dissipates heat.
And the striated muscle that pulls the testes closer to the body.
That's the cremaster muscle, an elongation of the internal oblique muscle. It consists of loosely arranged striated muscle fascicles, predominantly slow oxidative type I fibers. Its contraction moves the testes in response to temperature or fear.
And that's a useful reflex clinically.
The cremaster reflex is an important clinical tool used to assess spinal cord segments L1 and L2 and to help diagnose testicular torsion.
And the deepest layer.
Deep within this musculature, we find the fascias, and finally the innermost layer, the parietal layer of the tunica vaginalis. This is a serous membrane that defines a cavity. An abnormal accumulation of fluid in this cavity, derived from keratoneal fluid, is called a hydrocele.
We've navigated the entire system from the initial genetic blueprint to the functional output, structure by structure. We covered the precise genetic and hormonal control of testicular development, the TDF, MI, and DHT cascade.
Right.
The marathon 74-day manufacturing line of spermatogenesis, the essential protection provided by the Sertoli cell and the blood-testis barrier, the specialized duct system for maturation and transport, and the complex mechanics and clinical issues related to the prostate, BPH, PSA, and the mechanics of penile erection.
If we connect this back to the bigger picture, you now understand the extraordinary structural demands placed on this system. The insight here is the constant collaboration required between highly specialized cells that cannot survive without each other.
A total codependence.
The Sertoli cell needs the Leydig cell's hormone, the germ cells need the Sertoli cell's protection, and the sperm need the accessory gland's fuel.
Here is a final provocative thought for you to consider. The biological decision to isolate the germ cells, not only behind the immune barrier, but also in a low-temperature environment outside the body, must have been an evolutionary necessity driven by the heat sensitivity of the delicate meiotic process. This isolation requires the body to engineer a dedicated, continuous 74-day assembly line that churns out 300 million units daily. This massive, continuous energy investment underscores just how intensely every other system, nervous, endocrine, and especially the unique countercurrent circulatory system, must collaborate seamlessly just to maintain this one highly specialized, vulnerable microenvironment.
A phenomenal example of biological engineering under extreme pressure. We hope this knowledge serves you well.
Until the next deep dive, stay curious.